In this PowerPoint, we're going to take a look at artifacts and troubleshooting. Artifacts are unwanted signals that often obscure the recording. Artifacts can come either directly from the patient or from the environment. The technician should do their best to eliminate artifacts from the recording, but in order to do that, you first have to recognize an artifact. This is why we started with looking at the AASM scoring system a few weeks ago to get you comfortable with what looks normal. The goal is just to recognize normal, good recording of our sleep study. Let's go on. So here I have two slides for you, or epics I should say, from sleep studies. One of them does not have artifact that is abnormal and will not repair itself on its own. The other has artifact where you're going to need to intervene. Can you tell the difference between the two? Take a good look, and when you're ready, go ahead and click to go to the next slide. Artifacts that originate from the patient are called physiological artifacts. This includes EKG artifact, that is, the electrical activity of the heart is being picked up in other areas of the body. Typically, this occurs when you put an electrode right on a bone, because the harder the surface, the more conductive it is. So if you get it right over a bone, you're probably going to get more EKG artifact. Movement, any type of body movement can cause artifact because it can obscure your EEG or your chin or your respiratory belt. So artifact is anything that obscures the image in any way. Typically movement, and once the patient lays still and relaxes, the artifact is gone. Sway, there can be a couple causes of sway. It can be due to sweating, or it can be due to respiratory artifact. There are a few other causes of sway. We're not there yet. We're just going to focus on respirations and sweat, as those are the two most common. And then you have snore artifact. Snore artifact isn't horrible to have because you usually can make out the EEG in between. However, if you can eliminate it, you sure want to. Artifacts that originate from sources other than the patient are considered from the immediate environment, and this includes things such as 60 Hertz. This is where electrical activity from other machines or equipment in nearby, your equipment is picking it up. It could be a refrigerator in the room next door, it could be a fan, it could be a computer, it could be a variety of things. Another one is called electrode popping or pen blocking. Let's go on. So in this slide, the question is, where is the artifact coming from? So to determine this, you need to first figure out which channels it's occurring in. And then by looking at this, if you take a close look, it's pretty obvious it's not in our respiratory channels, and it doesn't really look like it's in my snore channel. It doesn't look like it's in my legs. It's not my EKG. It's not my chin. But then when I look up at my EEG channels, it's hard to tell what each channel is because the letters are too blurry, but I can tell it's in channel 3, channel 5, and it looks like channel 7. So it looks like channel 1 and 2 are my eyes, and then it looks like I maybe have a frontal lobe. I'm guessing on that one, it's really hard to tell. And then it maybe looks like a central lobe, occipital lobe, and occipital lobe is my guess, but it's hard to tell. So then I kind of can tell out the reference electrode on these channels. On channel 3, it looks like it's F4 to M1, although I'm really guessing here. I'm really straining to see that. On channel 5, it looks like it's C4 to M1, and on the last channel where there is artifact, it looks like it's O2 to M1. So by looking at this, it is not in all of the EEG channels, it's in select channels, and the thing those channels seem to have in common is the M1 electrode. It looks to me like the M1 reference electrode must be bad. We're having some sway, some artifact in here. It could be because the patient's sweating right there. This could also be considered somewhat of a pop. This electrode is popping and causing us some artifact. Let's go on. So artifact, how do you know where the problem is? And I just kind of walked you through the process of looking over your study and really narrowing it down. And so really what you're doing is you're looking at your montage. You have to determine where the problem is, and then you can determine what the problem is before you can fix it. So where is it at, and then what is causing it? What do I look for in the montage? First question you should ask yourself, is it happening in all of the EEG electrodes? If it is, then you know it's a problem with your major system. So either it's a ground electrode or it's your system reference electrode. You want to check your impedance on those because probably the impedance is high. Or maybe that electrode has disconnected from a scalp a little bit and you need to go back in and reattach it. If your answer is no, it is not in all of the EEG electrodes like our example, then you want to identify specifically the affected electrode. Is it in an exploring electrode? That would be it was only in one channel, like either C3 or C4 or F4. Or is it in a reference channel? Meaning you're going to see it in more than one channel because remember we use M1 as one of the references and M2 as the other. So using either one of those, you're going to find that artifact in more than one channel. Next thing you're going to do is once you narrow it down is you're going to check the impedance. Is it high? And does the electrode need reattached? If your impedance is high, you have to go back in, re-prep, and reapply your electrode. Let's go to our next slide. What does the problem look like? Is it a flat line? Is it something that's obscuring all of the EEG? Would you describe it as a spike or as a pop? Is it rhythmic or is it swaying? These are all descriptors of how you could describe the artifact. The next thing you want to do is look at your patient. What are they doing during the artifact? And then you want to document. You have to remember, you are the eyes and the ears of the physician. Your job is to gather reliable, accurate data. And so you need to document if you see your patient moving during the time of the artifact. Is movement the cause of the artifact? Well, in this situation, on the example I have here, you can see the EEG is somewhat obscured. This is a result of patient movement. Once the patient lays still, which you can kind of see at second 28 and 29, it all goes back to normal and it's easy, a nice clean signal again. Let's go to our next slide. Physiological artifact. Remember, this is something coming from the patient's body. EKG, movement, sway, or snore. These are all caused by the patient. We should never change our filters to try to fix these types of problems. One alternative we can do is re-reference the electrodes. What I mean by that is, let's say that you have a problem in your C4 electrode, and you know this because on your montage you have C4 to M1, F4 to M1, and O2 to M1, and the only channel where you see a problem is in the C4 channel. Rather than going in and waking your patient up at this point, you could, in your montage settings, change C4 M1 and change it to C3 to M2. That electrode should be good. If that electrode is good, you have a nice clean signal, then just leave that one in there for now, and the next time the patient wakes up would be an opportune time to go in and fix your electrodes. The other thing you can do is if it is blocking into another channel, you could adjust your gain or your sensitivity. You just want to be very careful anytime you do that you remember you made those changes. And realistically, you want to go in and fix the electrode if that's the problem. With your snore, if your snore channel, like when they snore, if it's making so much muscle activity that it's going into another channel, that would be a situation where it would be appropriate to use your gain or your sensitivity to adjust and keep it from blocking into the other channels. Let's go on. EKG artifact. The problem with this is that the EKG contamination is found in channels other than just the EKG. You can confirm this artifact when it lines up directly with your EKG channel. Your solution is try to remove the affected electrodes off the EKG pulse, or you could do what's called double re-reference. What this refers to is, I used to call it always tying the ears. And so, for example, we could take F4 to M1. Instead of using that, we could do F4 M1 plus M2. So you're tying the ears together, or you're linking the ears together and using the combination of the ears as a reference rather than just the F4. Or just the M1, excuse me. The reason we do not routinely do this is because you are going to lose some of your data. It's minimal. It's acceptable to tie your ears, but you never want to start your study out that way if possible. Let's take another look at this on our next slide. So here's an example where you can see EKG artifact in all of the channels. See how they line up with the EKG? I have a few circled there to show you how it's in every single channel. So again, you can do what's called double re-reference your channels, or tying your ears. And when you do this, when you use M1 and M2 to reference these channels to, it uses common mode rejection to eliminate that artifact. Remember, common mode rejection, it eliminates anything that is the same in the two channels. So by tying your ears, they both will have the EKG artifact. So when we do that, the EKG artifact will disappear, or it'll cancel each other out. Let's go on. Movement artifact. The problem here is you have bursts of high amplitude signals, meaning the electrical activity is so high on your tracing that is running into your other channels, and you can't tell what's happening in those other channels. Typically, we see this during wakefulness or arousals, or when the patient rolls over to their side or whatnot. Typically, this problem will resolve on its own, and you don't need to do anything. In some situations, sometimes at the start of the night, you will just be kind of at your wit's end with all the muscle activity. Sometimes people clench their jaws before they can relax to go to sleep, but once they fall asleep, that muscle activity should decrease. Let's go on. Here's a good example of your muscle activity or movement activity. And again, once the patient relaxes and goes back to sleep, that will go away, and it'll look like a normal sleep study. Let's go on. Sway artifact. The problem with sway is you have high amplitude, rhythmic, slow waves seen in the EEG channels. So what this means is, rather than your nice straight EEG channel waves, they bounce around, so to speak. The solution is you need to go in and either fix your electrodes or turn on a fan for the patient, or it could be respiratory artifact. So we're going to take a look at a couple of examples on our next slide. So here we have two different slides, both of which have sway. These are examples of two different types of sway. I want you to, first let's take a look at the one on the left, and look very closely at the top two channels in purple, and do you see any sway occurring there? Next, I want you to look at the blue and black channels right below it. And do you see sway in both of those channels or just one? Next, I'd like you to look down at your airflow signal. It is under the green line and above the EKG. And now see if that correlates with any of the waves that you saw up in your EEG. Okay, now let's take a look at the picture on the right. Again, start up in the purple, and what do you notice up there? Then let's move down to the blue and black lines. Take a good look at those. Do they all look like they're swaying? Do some seem like they're swaying worse than others? Lastly, check out your airflow and your EKG lines. And do they exactly line up with anything, or are they a little bit more random? Let's go to our next slide. Okay, the one on the left, this was a respiratory artifact. The wave or slow waving on your blue EEG signal specifically coincides specifically with the respiratory channels. In this option, or in this situation, they're using the C4 to A1 derivation. We could change that to C3 instead of C4 for the time being, and then when we had an opportunity, we could change that electrode. The one on the right, those are actually all somewhat affected. The one least affected is probably the blue channel, but really all of them are being affected. And the best fix for this one is to cool the patient off with a fan and you might have to reapply the black electrode. That one actually looks like it's the worst, but you would not want to let this go on. You need to take some action and fix this, because this is really hard to score. You wouldn't be able to really tell what stage of sleep the patient's in. Let's go on. Snore artifact. The problem with this is that snoring causes bursts of high amplitude, and these are fast frequencies in the channels other than the snore. So it looks like a lot of muscle activity, and you can see it sometimes in this example. You can see it in all of your EEG channels, your eye channel, your chin channel, as well as your snore channel. So in this situation, turning down your gain in any of those channels is not going to fix the problem. It actually is it's just the muscle activity. You can't fix that. So the only way that will resolve is when the snoring is eliminated. But let's take a look at another example. 60 hertz artifact. With this problem, you have high amplitude, fast frequency that obscures your data. This can occur in any of your AC channels. The most common cause is high electrode impedances, followed by interference from other equipment. Other equipment would be like a refrigerator in the next room, or another computer in another room, or a TV. Anything electrical is going to release activity, and your equipment can pick it up if the room isn't filtered right, and if your wires aren't not filtered but buffered right, like soundproofed right. The solution is to fix a problem, so you can go in and re-prep the skin and reapply your electrode. Make sure you get your impedance down. Remove any electrical devices from the bed, such as cell phones, DVD players, etc. Your last resort is to turn on your notch filter. Typically, we want to fix the problem if we can. You don't want to cover it up if you can at all help it. This is a common question they'll ask you, and they will give you the hint that you have already reapplied your electrode, and in that situation your answer is going to be to turn on your notch filter. Let's go on. Okay, in this example, the red arrow is pointing to the 60 hertz activity, or the 60 hertz artifact. So you can see how it kind of becomes kind of just a little black blob of activity there. Let's go on to our next slide. Okay, electrode popping. The problem here is you have short bursts of 60 hertz activity or high amplitude distorted waves. Typically this is because your electrode isn't on securely, or you don't have enough paste, or the patient has pulled it off slightly. So your solution is to go in and fix the problem. In some situations you can re-reference. In other situations you need to just go fix it. If it's happening very rarely, like once every 10 or 20 minutes, like it is on this, there's one pop on the whole page, you probably could let that go until the patient wakes up rather than go wake them up. But if it's something that's happening frequently, like several times on an epic or every epic, then you want to definitely go in and fix that. Okay, in this slide, can you find the artifact in the snore channel? Okay, hopefully you found the electrodes popping, and in this situation you probably need to go in and resecure your snore lead. Let's go on. Pen blocking. This, I think, is probably one of the more common situations you're going to have, and this is where your waveforms block off or square off. You can see how it goes really high and then you see a flat line, so you really can't tell what's happening. You can't tell the frequency of that wave because it's all jumbled. And the problem is your wave is getting too high for your tracing to capture. You're getting outside of your limits, and so it's blocking off. So your solution to this is you can either decrease your gain, which will allow the wave to deflect fully, but a better option, and especially for the picture we have here, is to actually go in and fix your electrodes. This is unscorable, so you need to go in and fix these. Okay, in this example, can you figure out which channel needs to have its gain changed? And how would you change your gain? What happens when you increase your gain, and what happens when you decrease your gain? Okay, this is something you really want to nail down. Let's check out our next slide. Okay, so here you go. When you increase your gain, you increase your height. So I don't know how you can remember that, but up in gain equals up in height. And then sensitivity is going to be opposite of that. So as you up your sensitivity, you get shorter. I do not have a good way to remember that other than gain and sensitivity are always opposite of each other, and gain goes up, kind of like my weight. Okay, let's go on. Troubleshooting. A good technician must work to identify artifacts and eliminate them if possible. Technicians should never use filtering to eliminate artifacts. The reason for this is because we lose good signals. They become masked and distorted due to the artifact in our attempt to try and hide it. Filters should only enhance the data. Remember, we're trying to gather accurate and reliable data. When we start using filters, we're starting to mask our data. So this slide says take out the garbage, don't cover it up. So go in and fix your electrodes. Don't just try to hide it by changing your filters. Remember, an excellent patient hookup eliminates most artifact. Prep the skin the best you can to prevent a headache for yourself later. This means good scrubbing, and I like to go over each spot with alcohol after I have scrubbed. And then make sure it dries really well before you apply your electrode. Your low frequency filter and high frequency filters should not be adjusted, never ever, and re-reference first and then replace if needed or when the opportunity allows. Don't underestimate the power of biocalibration or your physiological calibration. Many problems can be solved before you turn the lights out. For example, ensure that all your electrodes are plugged in correctly and match your montage. Make sure your EKG is in the right channel. Check all of your impedances. If any are on the bubble, go in and fix them before you start recording. You're just going to save yourself some pain there. And lastly, when troubleshooting, it's best to have a system in place to fix the problem. For example, either you can start at the patient and work towards a machine. I also have some people who believe in starting at your machine and working towards a patient. I personally always start at my patient. Reason being, like I said before, the better your patient hookup, the less artifact and less problems you're going to have. So I always double check my impedances first. Then I check and make sure they're all plugged into my head box correctly. Then I make sure that my cables are all attached to my system correctly. Then I go to my machine, I check my filters and settings and my montage and make sure all my waveforms match and make sure that I've calibrated it correctly. So whichever system you use, and you're going to be relying on your clinical site for this pretty much too, because they're going to have a protocol you need to follow, but you want to have a system. It should be logical. It should match the artifact you're viewing. For example, if you have artifact in your EEG channel, you should not be looking at your respiratory belt and seeing if there's a problem with that. So logical, identify where the problem is, figure out what is causing the problem, and then remedy. All right, good luck on this week's quiz. Please, please, please email or post questions if you have them for me. I am here to help.